Pain is a subjective sensation and there are pain scale for quantification. Shows the pain scale shows a different facial reactions, but we should understand that this can vary from person to person depending upon the tolerance status of the patient.
The treatment of pain is mainly the medical therapy. But if the conventional medical therapy fails, we have to go for nerve block. These are called local anesthesia. These are local anesthesia. So here coming to the medications, that is first is acetaminophen, which is paracetamol itself. It have a analgesic action. It have a antipyretic action, but it does not have an anti-inflammatory action or anti-platelet action. So how it act? So we all know these are the pathways in which certain prostaglandins, prostacyclins, thromboxanes are formed from membrane phospholipids. So you clearly observe here from the membrane phospholipids, arachidonic acid to amylopeptidase, there is cyclooxygenase pathway, which is blocked by the NSAIDs that prevents formation of prostaglandin, which is a mediator of a maximum dose or the dosage range of this acetaminophen is 325 to 1000 milligram, can be given Q4 to Q6H. Acetaminophen is better safe in gastritis compared to the phenoacyclodiclo drugs. You should understand that the maximum dose that can be given is only 4 gram per deciliter per day. Sorry, 4 gram per day. In case of a liver disease patient, it could be 2 gram per day. Adverse effect can occur if there's a 10 to 15 gram per day. It can cause a hepatic necrosis. Okay. Next, we deal about a drug called aspirin. These are analgesic, these are antipyretic, anti-inflammatory, and antiplateletic drug. Very important drug that we use in coronary artery disease patient. It should be used with caution in patient with a bleeding disorder, renal, and hepatic failure because these are excreted through these organs. You better avoid in pregnancy. Okay. The antiplatelet effect, it lasts for 1 week. The dosage range is 325 650 milligram Q4H. The maximum allowed dose is 4 gram per day. The adverse effect, you see the adverse effect as a bronchial asthma, that is aspirin induced asthma, laryngeal edema. You see aspirin induced asthma occurs in case of, you see here, the arachidonic pathway will go for the formation of prostaglandins, and that is cyclooxygenase pathway. Another pathway, that is LOX pathway, lipoxygenase pathway, forming the leukotrienes. So when a drug that is the aspirin, if a drug like aspirin, if it blocks this pathway, if it blocks the COX pathway, automatically this pathway will take over and the leukotrienes formation will be higher amount. And that can lead to triggering attack of asthma because these are bronchoconstrictions that can occur. These are the triggering factors. So there are chances it can cause such problem. And it can also cause laryngeal edema, urticaria. But patients with asthma and nasal polyps are more susceptible. You have very much heard about a Samter's triad. Okay, Samter's for the allergic eosinophilic rhinitis. Samter's triad, which include in three, like there are sensitivity to aspirin, there is asthma, there are nasal polyps. It's a triad. Okay, Samter's triad. It is that we use the NSAIDs. Next is the opioid analgesics. Very important. Opioid analgesics. When you are dealing with opioid analgesic, you should understand that what are the effect of opioid analgesic, how they act. The opioid analgesics are pharmacologically similar to opium or morphine and are the drug of choice when analgesia without antipyretic action is desired. So here comes. Here comes analgesia is required. without antipyretic action. In such case, we go for the opioid analgesics. Okay, you see, there are some equipotent doses of opioid analgesics. You can hear that there are fentanyl, levorphenol, hydromorphone, methadone, morphine, oxycodone, codeines. There are some examples of these drugs. Fentanyl. We have heard about this fentanyl drug in anesthesia. Okay, the duration of action is very short, since that is why it's used in anesthesia. 1 to 2 hours only action duration. Next is methadone. You have heard about methadone. The duration of action is 4 to 12 hours. Next comes the morphine, the prototype drug morphine. That's about 2 to 4 hours action. Okay, so there are many different drugs that we learn subsequently. The parenteral and transdermal administration are useful in setting of dysphagia, emesis, or GI absorption difficulty. You see, agents with short half-life such as morphine should be used, because we promote this drug. Why? Because it is having a short half-life and better for using. That is why we are using this one. Okay, the narcotic naive patient should be started on the lower possible dose, whereas the patient with demonstrated tolerance will require higher dose. The patient controlled analgesia is often is used to control pain in a post-operative or a terminally ill patient. Okay. The opioid naive patient should not have basal rates prescribed due to risk of overdose. So now we'll discuss about some selected opioids, that is codeine. We heard about this drug in in cuffs and suppressants like that. So these are mostly given in combination with, they are given in combination with what? With aspirin or paracetamol. Here we comes a drought. We must ask that why these are combinations are required. The trials have shown that the combination, that is codeine and paracetamol combination, provide greater pain relief versus placebo, and that these results are generally superior to the pain relief effect obtained from combination of codeine and NSAIDs versus placebo. That's why. Okay. Next, oxcodone, oxcodone, oxycodone, oxycodone, and hydrocodone, available orally in combination with acetaminophen. Oxycodone is available without acetaminophen in immediate release and sustained release formulation. Care should be taken to avoid acetaminophen overdose. So mostly these oxycodone, they are seen in combination with combo with paracetamol. There are sustained release preparations. There are immediate release preparations. So you must think, or you must be careful. Don't overdose the paracetamol. Okay. Next comes the morphine. This is the king. Morphine. The morphine sulfate, that is the chemical formulation, include both immediate release and sustained release. Okay, there are two combinations, both immediate release as well as sustained release. Sustained release. The liquid form can be useful in patients who have difficulty in swallowing pill. Yes, of course. But the morphine should be used cautious in renal failure, because it can end up in toxicity. So cautiously use renal failure. Methadone. Next one is methadone. The methadone, you methadone. Dealing with methadone is very effective when administered orally and suppresses the symptoms of withdrawal from other opioids. Particularly when you are continuously taking opioid, the receptors are very much sensitized. When you remove that opioid, there are withdrawal symptoms. So preventing that, so prevention of such symptoms, use or preventing to precautionary we are using, we could go for methadone because that is suppress the symptoms of withdrawal from other opioids because of its extended half-life. What is the half-life? We know it is a 4 to 12 hour duration of action is there for methadone. Next, you see that despite its long elimination half-life, its analgesic duration of action is much shorter. Next is the hydromorphine. Hydromorphone is a potent morphine derivative. These are a hydromorphone is a morphine derivative. These are morphine derivative. 5 to 7 times the strength of morphine, and cautious should be used when ordering this medication. Okay, because it's 5 to 7 times powerful compared to morphine. Okay. Next comes the fentanyl. Though it is very quick onset of action and quick duration. That is onset of action is 7 to 8 minutes only. Onset, and the duration is probably 1 to 2 hours. You see that the fentanyl is available in transdermal patch with sustained release over 72 hours. Initial onset of action is delayed. Respiratory depression may occur more frequently with fentanyl. The transdermal patch, the onset of action is very less, but when you're using in anesthesia, the onset of action is very quick when you're using it in an IV form or form. It can cause respiratory depression, very more important point. So very careful, okay. Respiratory depression. You see, what are the precautions that you take when you are dealing with opioids? Precautions. The first precaution that I take is you head injury patients, you avoid opioid. Why you avoid opioid in why opioids? Then it can be brain depression or it can be intracranial pressure increases. Intracranial pressure, it increases the intracranial pressure. That's why. Next, the opioids are very much cautiously used. You see in hypothyroidism. Why? Because opioid will increase thyroid binding globulin. When the thyroid binding globulins are increased, it increases the thyroid binding globulin. When the thyroid binding globulins increases, it attaches or it absorbs or it holds the thyroid hormone, causing a relative hypothyroidism. Also in Addison's disease, you see Addison disease, you heard about Addison disease, hypocortisolism. In Addison's disease also, OIAI, what is that? It's a opioid induced adrenal insufficiency. Like the opioid may suppress the axis, that is hypothalamic pituitary axis, that is suppressed by the opioids. That's why it is a opioid induced adrenal crisis or insufficiency occurs. Similarly in hypopituitarism, in asthma, because it's bronchoconstrictions can occur. Kyphosis, scoliosis, severe obesity, malnutrition, and debilitation or chronic coral pulmonale. The drugs that potentiate the adverse effect of opioid include phenothiazines, antidepressants, and benzodiazepines and alcohol. So, drugs that potentiate action of opioid adverse effect. There is opioid adverse effect potentiation. So there is phenothiazines. Phenothiazines are antipsychotics. Then certain antidepressants. Then benzodiazepines. alcohol. These all potentiate the adverse effect of opioids. The tolerance develops with chronic use and coincide with the development of physical dependence, which is characterized by withdrawal syndrome. When you are seeing about withdrawal syndrome, there are anxiety. Withdrawal syndrome, what? Withdrawal syndrome, there is anxiety, diaphoresis, there is sweating, then GI distress, temperature instability. When the drug is stopped abruptly, these occurs. These withdrawal syndrome. That's why we are most commonly we use this methadone after 2 weeks of therapy. Administration of an opioid antagonist may precipitate withdrawal after only 3 days of therapy. Tapering the medication slowly over several days can minimize the withdrawal effect. Okay, so better taper. Adverse and toxic effect. We're seeing the adverse and toxic effect. You first think about the central nervous system. What will happen in central? The centrally, when you are discussing, there are sedative drug, that is morphine, euphoria, pupillary constriction, meiosis, that is meiosis out of it, there is sedation, respiratory depression, pneumonia, hypotension, infrequent constipation like that, nausea, emesis. When comparing is coming to respiratory system, right, there will be respiratory depression, cardiovascular system, hypotension, and peripheral vasodilation. And side effects, what is it? It include constipation, it can be nausea, vomiting. That is why we told the E, this is emesis. Next, opioids may precipitate toxic megacolon in patient with IBD. Toxic megacolon. It precipitate in whom? In patients with IBD patients. Okay, in IBD patient, it precipitate toxic megacolon. Genitourinary effects include genito, that is retention of urine. Retention of urine is very important. Retention of urine it causes. Next, you see that pruritus occurs most commonly with spinal administration. Why? Spinal administration of opioid pruritus. Why? We don't know the exact reason. Probably the muscle releasing, the immune system releases inflammatory histamine, such things. What happened if the opioid is overdose? Overdose of opioid. The symptoms we can easily find by mnemonic called morphine, that is meiosis out of it, respiratory depression, pneumonia, hypotension, that is constipations or infrequency, that is constipation, retention of urine, nausea and emesis. So opioid overdose, we use a drug called naloxone. Naloxone is a drug that we use in case of opioid. See this. This is an opioid. The naloxone binds to the opioid receptors, reversing an overdose. Okay. See here. The naloxone has a stronger affinity to the opioid receptors than other opioids or heroin. So it knocks the heroin off the receptor for a short time and let the person breathe again like that. You see. In opioid receptors, these naloxone, which are marked as red, will bind and try to throw out the blue arrow, that is blue triangle, that is opioids. Alternative medications. First is tramadol, the most commonly used drug. It's an opioid agonist. So opioid agonist. And they are acting centrally. Centrally acting non-opioid analgesic. The dosage we use is 50 to 100 milligram per oral Q4 to Q6H. For elderly patient and those with renal or liver dysfunction, dosage reduction is recommended. Adverse effect. The concomitant use of alcohol, sedatives or narcotics, it should be avoided. Okay. And respiratory depression has not been described at prescribed dose but may occur with overdose. Tramadol should not be used in who are taking monoamino oxidase inhibitor. That is adverse effect. You see, tramadol is not should not be used in patients who are taking MAO inhibitors because it can trigger serotonin syndrome. That's why, okay, should be clearly focusing on that. Then certain other drugs like anticonvulsants can also be used in pain management. That is a gabapentin, pregabalin. You can use carbimazepine, oxcarbimazepine, like that. And TCA, duloxetine, that is SSRI. Then topical anesthetics. Topical anesthetics we all know. Lidocaine. This can also be used. Thank you for listening.